I'm Chris Crawford. I'm a clinical operations manager for the Vernon Jubilee and Shuswap Lake. I'll introduce Laurie a little bit more. Dr. Vane, she's an internal medicine physician in San Bernardino at Shuswap Lake Hospital. She's extremely passionate about cardiac care and rural healthcare and equity. And it's been a real pleasure working with her on this project.
Thank you. A year ago, if you would have told me you'll be here today, I would have said you're crazy. The other thing is, if you told me I would have been here with Chris, you would have said, are you insane? Chris, a year ago, from my perspective, was a useless manager in Vernon Jubilee Hospital. Knew nothing of what seminar needed, and I was like, why are we in his portfolio? So, in the summer last year, I actually reached out to the manager in our hospital and said, hey, any way you could add us to your portfolio and get this guy out? And she said, sure, but let me introduce you to him first. So there was this email. And anyway, she said, hey, I'll let you guys talk now. And it actually turned out to be quite impressive what we were able to do together. We met before, again, PQI even approached us. We had a good conversation, honest, blunt, with a lot of things we wouldn't say in public, but anyway, it was really refreshing to say, oh, actually, we do want the same things. We do want to get this department better. So Chris, to me, he's now a very good colleague. I'll say friend, but I don't think you're my friend. And just going back to the title we chose, the IH dyadic model success story. I think everybody in this room here could agree that their success is attributable to their own dyad. And I think we just wanted to bring that forward because as opposed to everybody else here, we really suck at everything else. So, problem and the background. So, what happens is that the Shuswap is actually a fairly elderly community. About 35% of people are greater than 65 as opposed to the 19% average, Canadian average. So we're looking at a lot of people with heart problems. And so we didn't even know where to start. There's so much better things we could do in Seminar for those folks that are elderly. And we decided that we could tackle something that's really small. So diagnostics. How were our benchmarks last year?
So we were about 3 times behind benchmark on every single diagnostic modality we ran out of cardiac services. I mean, in my defense, that predated me by several years, but definitely set the framework for the opinions on our dedication to Shuswap Lake Hospital.
Mm-hmm. And when you wait till you diagnose a condition, meaning you wait for a stress test, you wait for a Holter monitor, so cardiac monitoring, then your patients suffer, and then your system also ends up paying more because they go back to the emergency room with the same question again, got chest pain, and then they send you back. So we thought it would be a small thing, but doable. That's what we did.
So what we decided we should probably do was take a look at reducing that delay. To meet benchmark on these, we actually needed to improve by 30%, and so that was for Holter monitoring and stress tests is where we focused our energy.
This is a picture of Chris at the wrap-up meeting, and that was before he jumped onto the stress test to impress us with his cardio capacity. Yeah.
I didn't impress anyone.
No, he didn't. So, change ideas. We had a lot of ideas. Sorry we didn't do the nice PDSA drawing because really we're more in the red section and saying we just do things. But we had a few ideas, so I'll let you go through.
Well, yeah, we probably had too many. I mean, that was one thing that was really helpful through running the structure of PQI when we sat down together and looked at all the things that we wanted to do to improve access. the list was really big, and it was pretty significant and somewhat daunting. So as we focus that down onto what our actual aim statement would be, as we broke that down into what our cycles would be, first we needed to clear the backlog, and that wasn't insignificant. We needed to clear the backlog before we could maintain it. And we've got some amazing graphs, thanks to Lindsay, that we're going to put up here in a second. But we actually had to double our previous capacity for several months, with very few resources that were sent there. We really needed to re-look at how we were actually booking and some of our booking processes. And so that was a really exciting and interesting thing to try to understand how outpatient booking standards should be. We also had to really optimize the work of our techs, and that was a bit of a challenge, and bring us into regional standards for test time. As an example, we were running ESTs in 45-minute appointment slots when
everybody else.
Lots of places can do it in significantly less time.
Yeah, and that was with the booking team at the same meeting where we ate some Thai food, I believe. That was good.
Yeah, food does a lot to bring the team together. And,
yeah. So this is our table 1. So we looked at 2 modalities. I said we tried to reduce diagnostic test times, but one of them was the Holter monitoring testing. So what happened there on this graph is that on average, a patient prior to this was waiting an average of a mean of 51 days before getting their Holter monitor hooked up to their chest after the family physician or the specialist would order it. Through a series of change ideas, including the new scheduling changes, we were able to reduce that by 10 days or more than 10 days, so therefore 23% reduced wait for Holter. The thing is, we can't really calculate a return on investment because we literally did not invest anything other than just our brain. So we had a few extra devices that were shipped from the regional fleet, and we had a 0.2 FTE addition to our cardio tech, and we changed the scheduling, and then we got these results, which I think we're quite pleased with, and they're maintained at 4 months. For the table 2, I don't know if you wanted to add anything.
No, I mean, with the FTE change, it's important to know that realistically represented about a 10% increase in the department, but produced greater than a 10% increase in our throughput.
Well done, thank you. So for table 2, we went to look into stress tests. So these were the number of stress tests performed in our department per day. So at the beginning of this project, before the project started, when Chris was still a useless manager in Vernon, the mean was 3.9 stress tests per day. And then I can let you figure out when our first conversation was. It was actually October, well, end of September, and just by talking. And sorry, that's not very PQI. There's not a lot of data there, but we literally started collaborating on that day, and it increased by more than, it's more than 20% on the first go. And then when we started working together more and everything, we were able to also increase further, and then the total number of stress tests per day increased by 44%. And that's, again, out of no investment other than our thinking. Did you want to talk about that?
So interestingly enough, we increased the throughput by 44%, but our wait time, I mean, that's not a graph we're showing you right now, it didn't change. So you build it and they come, and we increase some demand, but with that understanding, it actually kind of leads us into some of our lessons learned and reflections on this. Particularly around stress testing, it was very difficult to have a dialogue with the provider group to change the status quo. The vast majority of them felt that weight and volume was appropriate, and they're heavily tasked too, so weren't terribly interested in adding more work to their day for something that they didn't appreciate as having value. we actually just finished a meeting with that group last week, 2 weeks ago. And now there is interest in kind of optimizing their scheduling, which will help us catch up on the wait time anyway.
Yeah, and somebody asked me, is that an engagement? And I won't say, but it was actually my husband, and I was like, oh no. So I will tell you later, at a later presentation, why this picture was taken. It is not because we're getting engaged. Next slide. And then, so I just wanted to thank Carol, we call her Carol, Ellie, and Lindsay, who actually, everybody says Lindsay's so great. I had to say it. His fiance is even better. Awesome. So thanks also all the PQI for allowing us to work on this and have some dedicated time for Chris to dedicate to Salmon Arm Day.